talk about active disease. So we're going to separate it into two different kind of disease states. So we'll start with latent. So in latent, we always want to rule out, make sure there's not active disease before we start a prophylactic treatment of TB. There are, at the end of your handout, two tables that have schemas. One is for latent, one is for active tuberculosis. I put them in there not for you to memorize, but I think that tables are very good for comparison. Sometimes in learning you can look at what's common, to kind of see another way that people have organized it. So as I go through, I'll tell you some doses and regimens that I want you to be familiar with because they're very common, and the rest of them we're not going to worry about at this point. On the very last page, 14 gives you all the drug regimens for active. There's quite a few, there's 4 of them, and then they even subdivide. I want you to be familiar with the 1A, 1A. We've talked a lot about adherence in our short time that since you started the program. And so we talked about adherence problems with even short term, like 2 weeks of antibiotics or 10 days of antibiotics, and how people quit taking things because they feel better. So you can imagine if you're going to ask somebody to take a regimen for 9 months, how adherence is really a problem. So did he talk about DOT? Did he talk about directed observation therapy? He did, okay. So that came about, that's been around for a while, but came about because the disease is so hard to treat and get people to be adherent to it. And adherence equals success. So if you can get people to take the drug, you can get a 95–98% cure rate. And where we don't get, the reason why the disease still persists is that we can't always get good cure rates because of the complexity of the regimen and sometimes the intolerance of the drug therapy. Okay, so let's talk about the 2 of the agents right off the bat because they're used. So the preferred are INH and rifampin. They always form the basis of your therapy unless you have INH resistant or rifampin resistant organisms. They'll always be a part. And people refer to isoniazid almost exclusively as INH, so that's what I will call it. Most of these drugs are all going to work on the cell wall. The cell wall of the Mycobacterium is fairly complex. And so different pieces of it are different parts of it are what the drugs are directed after. And so INH works on that glycolic acid synthesis, so that the organism isn't able to repair or to generate or to keep the cell wall intact when INH is present. It's bactericidal, so it's very effective. It's effective at whether the organism is actively growing or dormant. So that's why we can use it in latent TB or in active TB. I do want you to know the dose, so underline it or highlight it. That 300 milligrams per day is just you'll see it in almost everybody. So this is for adults. Maximum is 300. Most adults are put on 300 daily. Right below that, I want you to notice that grade-in box that I gave you. So this kind of brings up something I don't think we talked about in the introductory lectures, but black box warnings. Always pay attention to those. They are put in a label by the FDA, usually after a drug's been on the market, and a significant or serious hazard or adverse reaction has been noted. Usually the drug is valuable enough that we do not want to take it off the market. Sometimes we will if it's that it becomes that common. But black box warnings usually are going to tell you about a serious adverse event. Okay? And so for INH, it has a black box warning against hepatitis. So this is a fairly common problem when you use the TB drugs. Rifampin, pyrazinamide, and INH, all three can cause hepatotoxicity. So hepatitis just means inflammation of the liver. Usually it's a virus that causes most of it, but there are several drugs that can cause significant hepatotoxicity and can lead to significant impairment of the liver or death due to liver failure. So the people who are at most risk are usually those who drink alcohol. So we ask people to don't drink alcohol when you take this drug. So you can imagine if you ask someone for 9 months, don't drink alcohol, that usually is going to impair your adherence. Because what they will do is they will stop the drug and drink the alcohol. So if they're going to drink, they just won't take the drug. So that's why patient education is really important with the TB drugs. It's why you're going to see them usually on a monthly basis, because you're going to be asking these questions about side effects, adherence, and you're going to keep reminding them and educating them about the importance of taking those medications. So just going over the information that's there, it's usually age-related, so the older the liver gets, the more likely it is to be to have damage from these hepatotoxic drugs. Usually occurs early in the course of therapy, so usually in the first 3 months. So that would be an active phase, that would be in that initial phase, or in the first few months of treating a latent disease. Most of the time, and you will see, you'll monitor liver enzymes when patients are on these drugs about every month. You'll get a baseline for comparison. So when I say you get a baseline, you know what I mean by that. Y'all talked about, okay. So you'll get a baseline for comparison, and then you'll check them every month. Usually you will see transient rises. We see this with a lot of drugs. Early in therapy, the enzymes will go up, and then usually they will go back down to normal. Most of the time, if enzymes don't go over 3 times normal, for most drugs, we will just watch them. For INH, if the level of enzyme increase is 3 to 5 times over the upper limits of normal, then we will stop the drug. Because then the potential for severe and serious injury to the liver and potential liver failure is too great. Another really important part of the patient education is telling the patient, here is what this will look like. So if you get liver disease, here's what's likely to happen to you. You may get sick to your stomach, you may vomit, you may have abdominal pain. Your urine may turn dark and your stool may turn white. So bilirubin in the urine can't manufacture a bile acid, so your stool, or bilirubin, so your stool becomes a light color, even a clay color. Not red clay, light clay. Not red clay like Oklahoma. They may have a yellowing of their eyes or their skin, or complain of right upper quadrant pain. So telling them, if these things happen, you need to seek medical attention quickly. Stop the drug, and either it's an emergency room or it's call me the next day. And those should be emphasized each time you see the patient. Just repeating. Give them a handout, keep repeating those things. Some of these things would scare people. I mean, very dark urine, and this is really a very dark brownish red urine, or their stool's turning a very different color, will usually worry people, and they'll seek help. But some of the other things like nausea, vomiting, abdominal pain, you could attribute to just other things. Didn't eat right, a bug, someone else in the household is sick. Okay, so questions about those? Okay, so the other one is peripheral neuropathy. So a neuropathy usually is some type of loss of function of a nerve. It can be due to demyelination of the nerve, toxicity to the nerve, damage to the nerve. So the problem with neuropathies is that we rely on nerves to work well in order to protect us from harm or to tell us when something's wrong. So if your nerves don't work, and when we're talking about peripheral, we're usually talking about the legs, feet, hands. So if I touch a hot stove, those nerve impulses that go to my brain and then back to my hand make me move it away. If I have lost sensation and I no longer have that nerve working, then I can keep my hand on the stove for quite a while and never feel it. So that's why neuropathy is so important, and the loss of that sensation can be harmful to us, particularly in people who are at risk for neuropathies, like people with diabetes. So the problem here is that the drug interferes with the metabolism of vitamin B6 or pyridoxine. So supplementing those folks is important. So giving them a supplement, you'll see anywhere from 10 to 50 milligrams a day listed. If we have babies that are being breastfed by moms on INH, then we would give the babies pyridoxine as well. Let's see. Okay, any questions about that? So those are two big adverse effects. Usually the neuropathy is reversible once they're taken off the drug. Rifampin. So rifampin is another antibiotic, very potent, and it has many uses, but here we're using it to block the ability of the organism to make DNA, RNA. So it goes into the nuclear membrane and it disrupts DNA, or the RNA polymerase, sorry. So it can't make proteins, can't make DNA or RNA. Usually it is a drug that's fairly well tolerated, but it has some unusual side effects that you need to warn people about. One is that it will turn every secretion they have red or reddish orange. So their urine will turn reddish orange. When they cry, their tears can be stained orange. If they wear contact lenses, the lenses will become discolored because of the color. So warn people about that. The pharmacist should do that too, put a little note on the label about it. It also can cause a flu-like syndrome, and you want people to report that, because it can be significant. But it also can be that during this time of the year it would be hard for them to know the difference between the flu and that syndrome. It also can cause a petechial rash, which is a hypersensitivity reaction to the drug. So if they get little red dots, usually it will occur on the shins, like between the ankle and the knee. They'll get these, it just looks like little pinpoint bleeding. So having them report that can also cause a thrombocytopenia. If that happens, you have to take them off the drug. And I don't think you can restart it. I could be more wrong about that. The other thing with this drug, and I put that red flag out to the side, is it is very potent in terms of being a 3A4 inducer of enzymes. So when you see rifampin, you need to think this drug interactions and look it up. Look up the drugs that they're on and see if there's any big drug interactions. A big one would be, in young women, would be oral contraceptives. It will absolutely render them inactive. So it can terminate a lot of drug use, like anticonvulsants. We'll see that when we have HIV patients, the drugs that they're on to control their disease can be affected by rifampin. So always think drug interactions with rifampin. I put it down there to insert in your brain. Anytime you see rifampin, I need to check to see if this drug interacts with any drug my patient is on. All right. Breastfeeding and pregnancy. So INH, we can use rifampin. There's two caveats here. One is that when it is considered moderate to high risk for the pregnant woman, then we're also worried about the fetus being infected, then rifampin is appropriate to use. We don't recommend it being used during breastfeeding, whereas INH we could use. If you look down in that next paragraph or that next group where you have rifapentine, that drug is not recommended during pregnancy. And they're both out of that same rifamycin derivative. So kind of keep them separate in your mind, but they sound a lot alike, so just wanted to point that out. Okay, so those are your two base drugs. If you can't use one, you're going to try to use the other. And in some of the regimens, they're considered equal. Most of the time, INH is the preferred. That's the one you want to use if you can use it, and the patient can tolerate it. But it's a 9-month daily. So let's talk about who gets directed therapy and observed therapy, and who has self-administered. Did Dr. Harvey talk about that?
No.
Pardon?
Well, just a little bit.
Okay, so if you can have a person self-administer the drug, that's really what we would like. But you've got to ensure that adherence is understood and that they have the means by which to do that. So they can procure the drug. These are both generics. They're fairly inexpensive, relatively inexpensive at this point. So can they get the drug? Do they have the resources? Do they have the ability to self-manage and self-treat? Cognitive ability would be part of it. Physical ability would be part of it. If you have someone who is homeless or who is at high risk for a place to live, who has maybe social situations that put them at risk in terms of their money is at risk, or their living space is at risk, or they are at risk from other people in their home, then those you might want to start thinking about that directed direct observational therapy. Okay. Anytime you use intermittent therapy, you have to have the DOT. Okay. So self-administered, you're under a private physician, you've got means, you're resource rich, they use that term, then you can have self-administered therapy. If you're not, then they're going to recommend that you administer the drug using DOT. Okay. Questions about that? So I'm going to go down to the bottom, and that'll cover some of the rifapentine as we go through. So when you start a regimen, bottom of page 4, preferred are the two at the top. So INH for 9 months, self-administered, or weekly INH plus rifapentine for 3 months given by DOT. These two are considered equal in efficacy, because that second one, that INH plus rifapentine, in a very large study, multi-centered, multi-country, it was found that the outcome was what they call it non-inferior. So the combination therapy was non-inferior to the INH, meaning it was equally efficacious. But they found that the continuation rate and the completion rate and the efficacy was actually higher in that second group. but you've got 2 drugs you're having to deal with, and you have to use DOT. So that's why it doesn't supersede the INH. Okay, alternatives is the 6 months of INH. If you've got somebody you have no problems with adherence, and very low risk, they seem to be a very good patient. They don't have like capillary lesions. They don't have other factors that would make you want to go for a longer period of time, then that one is acceptable. INH and rifampin together is acceptable. Rifampin for 4 months, self-administered, is an alternative. Some people consider it as a better selection than INH 9 months because it does not carry the risk of hepatitis like you have with INH. It saves time, it's shorter, so some favor that over INH for 9 months. Okay, so those are your 5 options. We're going to consider the first 2 preferred, and we're going to consider the last 3 acceptable alternatives. For pregnancy, INH is again the preferred. Here it introduces, did you all talk about interruptions in therapy and how to handle that, or total doses in a given time? Okay. So you will see, and I think in some of the tables I've given you, it will say the therapy needs to be this many doses. Like for INH, it's 270 doses. They give the caveat in pregnancy that it could be over 12 months instead of 9 months if there have to be interruptions. The risk of hepatitis goes up greatly in the postpartum period, so if there's interruptions there, then the dosing can be extended to 12 months with interruptions. There are protocols for that. Mostly I just want you to be aware of that. When you get into those kinds of situations, that really needs to be, I think, done in consultation with people who are, that's what they spend their time doing, the specialist for TB. Don't forget the pyridoxine and the hepatitis monitoring as well. Okay, let's look at children. So children are at great risk because they tend to be, if you've got adults in the household, then they are going to be around people in close quarters with adults that are infected. So they are at high risk when they are in a family where TB is present. Again, with kids, it's INH. Kids don't do well with a high pill burden, so we tend to try to keep it simple for them. You can do the twice-a-week therapy. The adult max doses apply to kids. Kids are dosed on a milligram per kilo basis. Same toxicities that you worry about with adults, you're going to do the same with kids. They should also get the pyridoxine. Rifampin is an alternative for the kids. It does come as a capsule. You can dump it out. You can add it to food and administer it that way. I wanted to make a note about the INH and rifapentine. It can be used in kids as young as 2. It does need to be used under DOT though. And in HIV patients, does yours say INH 300? Okay, I caught it. I had 3,000 there and I saw that this morning. Here, it depends. Here you may have a lot of at-risk population in terms of the ability to self-administer the drug in an environment that will support that. So there are caveats about using that drug up to 3 years or 36 months, depending on, did he talk about HIV and TB together? Okay, so if you have that existing, you may have to have an extended period of time of treatment. I know he mentioned secondary drugs. I'm not going to spend a lot of time on those because I think that for you, what you all are going to do, especially if you're in primary care, you need to know those drugs that we just talked about. Secondary drugs are going to be resistant agents or resistant bugs, or you've got people who cannot take the preferred agents. So I've listed some of the most common go-to are going to be the fluoroquinolones and ethambutol. But I'm not going to hold you responsible for those. Just know that if you are working in a drug-resistant area, then those will become much more important. And there's a long list of secondary drugs that can be used. Okay, so items to remember. Drug interactions, really important with rifampin. Hepatitis, very common with INH and also rifampin. Don't want them to drink alcohol, going to monitor frequently. Treatment is discontinued for symptomatic patients when you get above the 3 to 5 times the upper limits of normal. Supplement with a pyridoxine. Those are the important. Okay, questions about those? Okay, let's talk about treatment of active TB then. Here the goal is to get rid of the mycobacterium, prevent drug resistance through non-adherence, and also prevent relapse of the disease. So in the initial phase, again, if you look at the table in the back, it lists out those regimens, and you can see where it talks about an initial phase and a continuation phase. So initial phase is 8 weeks, and the continuing phase is going to be 4 to 7 months. We always start with 4 drugs because of the worry about resistance. It's during that time that they can culture the bug and figure out what it is susceptible to. When I was in training, it was about 5 to 6 weeks to get cultures back. What did he tell you all?
I think he said you could step down at 1 month.
About a month, okay. So that's why you've got that 2-month period in there to just find out their susceptibilities. So you're going to start with INH and rifampin, pyrazinamide, and ethambutol. If you find that the bug is not resistant, then you can drop the ethambutol. Otherwise, you have 8 weeks of those 4 drugs. In the middle of the page, I talk about drug susceptibility being done. Ethambutol can be stopped. If you're using intermittent therapy, again, you're going to use DOT. I don't think I have anything else to add there. Let me say just a few things about pyrazinamide and ethambutol. Pyrazinamide we don't use in latent or in combination with INH or rifampin to a great extent is because it is a hepatotoxic. And so the risk of hepatitis goes way up when you use those combinations. So that's one of the problems with it. It's also a cell wall. It's not really known exactly how it exerts its effect, but if you look on the next page, it's thought to be in that phospholipid layer where it is causing a disruption and leads to the inability of the organism to maintain their cell wall and die. Weight-based dosing for kids and adults. The adverse effects for pyrazinamide, the 3 of them are, one, arthralgias. About half the patients will get polyarticular arthralgia. Also, elevated uric acid levels, so it can precipitate gout in susceptible individuals, and then hepatotoxicity. If you look at page 9, I have created you a table that has all the side effects. I think that's important for you all because I think that's one of the things that you would come across in a more primary care setting. The ones that are highlighted are the ones I want you to know. Mostly I want you to know what they are, what drug they're associated with. I've given you some brief presentation of how it would look. And then the comments are more to tell you here is either special circumstance or to give you a percent so it will impress on you to be looking for it. Or if you got arthralgias with 40%, We usually consider side effects really significant if it occurs in 5% or more patients. So if you've got 40%, then you're going to see most of your patients are going to complain. Okay, under ethambutol, the important thing there is under the adverse reactions is that you can get a retrobulbar neuritis. So this is one of the forms of optic neuritis. Remember we talked about that when we did the eyes? Okay. So it can occur in either one or both eyes. It's retro, so it is behind it's in the optic nerve behind the eyeball. So inflammation and swelling can lead to a lot of eye pain. Also changes in their visual field, so they may have blank spots in their visual field that they may complain about. They will have a visual color loss, so red and green are affected the most. If it's in one eye versus two, then they can have like a color desaturation, like the red just doesn't look as red, or the green doesn't look as green. So this would be something you'd want to be monitoring for every visit and asking them about. Okay, changes in vision, blurred vision could be another complaint, changes in color vision. Okay, so down on the bottom of page 7, continuation phase. So once you've got through the eight weeks, your sensitivities have come back. You know if the bug is you can treat, what drugs you can treat with. Then that starts that continuation phase. It's almost always going to be INH and rifampin together. So most people are going to have 4 months, so you're going to have a total of 6 months. Now some people will go 7. I believe pregnancy falls into that. Others would be, are listed there, those who have a cavitary pulmonary TB on initial x-ray or a positive. And this is another big thing you're looking for at that culture is are they no longer have a positive sputum culture. That's one of the things at the 8-week mark that will change or will impact what you treat with in terms of drug or how long you treat. If you could not use pyrazinamide in the initial phase, then you would treat longer. I've listed things, there's some things under duration therapy that are dictated by interruption therapy. I've listed that there for your information. I'm not gonna, it's complicated I think, and there are protocols to look at for that. The one thing I would point out is that last bullet, which is up on page 8. In general, continuous treatment is more important in the initial phase. So you think about it, because that's when you've got bugs that aren't being treated. So it's more important there in those first 8 weeks when your organism burden is highest and chance of developing resistance the greatest. The earlier in the course treatment and the longer the duration of interruption, the more serious the effect and the greater the need to restart from the beginning. So sometimes they'll restart people if their adherence has been so poor, or if the interruption has been too long, they'll just restart. Okay, monitoring and adverse effects. So we're going to go through this. Some of it's review. We've already talked about it. The ethambutol, again, visual acuity. So baseline, visual acuity, red-green, color discrimination. Adherence at every visit. Consider testing for HIV if it has not been done. Educate patients about the hepatotoxicity and monitoring for that, again, at every monthly visit. Repeat monthly hepatic enzyme measurements are not necessary in patients with a normal and no risk. You see different recommendations. Some will say monitor baseline and then 2 or 3 months, because at that 3-month mark is where you see most of it, and past that, then they'll recommend, if you've got a very low-risk patient, not monitoring. Here are listed some of the more common reasons for monitoring longer. One would be you've got an abnormal baseline. Drug reaction is suspected, liver disease, they've got a baseline liver disease. Pregnancy or in the first 3 months of postpartum, combination with pyrazinamide, in other situations where there might be hepatic injury, like other drugs they're on or alcohol or drug abuse. Other adverse effects, let's look at drug fever. It's at the bottom of that page. Have y'all talked about drug fever in any of your other things? Okay. So drug fevers they're really a diagnosis of exclusion. So if someone develops a fever and there's no known cause, you rule out every other cause that a fever would exist, and you have none, then you consider a drug fever. Drug fevers are hypersensitivity reactions, usually, the most common. And they will, when I have seen them in the past, what we usually do is we just start plotting everyday temperatures, and we start looking at patterns. And then we'll withdraw the drug. Usually when you take the drug away, the fever will go away. So you can't treat through these, because they're usually hypersensitivity, or the drug is working on or changing the thermal regulatory part of the brain. So it's important to note them. They're often ignored or attributed to other things, but it would be important to keep that in mind. These drugs it's more common with these drugs, and to rule that out when dealing with them. Sometimes they're just idiosyncratic. There's no other reason that you can figure. They don't show any other signs of hypersensitivity, but that's what there is the more usual cause. Okay, so page 9, I think I've hit all of these. So this is the summary of what I've talked about. Counseling points, I've hit all of those. Most of the time, most of these drugs can upset stomach. Most of them can be taken with food. We talked about symptoms of hepatitis, report visual changes, report the petechial rash. So special populations, HIV, that group is really a special population because of the drugs that you're using to control the HIV infection. There are problems when using the TB drugs. If you diagnose them at the same time, then you need to start the TB drugs first and then add the ART therapy or the antiretrovirals. I'm not going to test you over that. That is a complicated group to work with. Those I think you would find more in specialty groups. If you encounter them in primary care, the big things you will want to know is the drug interactions. Adherence, it's so hard for both of those diseases. So adherence and the likelihood, how do you monitor them, and then the likelihood of their side effects. So that's what I would be most conscious of in treating that population. Pregnancy we talked about in lactation. I do want to talk about the pyrazinamide. It's in the middle of that paragraph. The World Health Organization promotes the use of PZA in pregnancy. In the United States, we do not tend to do that because there's a lack of safety data, and because of other risk to the fetus, they don't recommend it. A couple of things with secondary agents is aminoglycosides can be used. The fluoroquinolones are secondary, but those have a lot of side effects on the infant or the fetus. So it's really hard to treat women with TB who are resistant to those first two agents. Where you're going to see that more is you're going to see them in patients who are refugees or coming in from other countries where there is drug resistance. That's where you're more likely going to see. You won't see it so much in the United States or just in limited areas of the United States. So when you're dealing with folks coming from other countries, that's when a lot of these other issues are going to be present. I think everything there I've said about the kids. There is a flow sheet on page 11 for active TB that I thought might help. And there's, on page 12, there's some review things. I'm not, it's more to help you kind of think through. I'm not going to use this or test you on that. I did want to point out that March 24th, which is Thursday, is TB Elimination Day. It's every year, March 24th. And then you have the last two tables. So that's all I have. Questions?
Those tables are awesome.
Yeah. And thank you for breaking that down for the test tomorrow too.
Oh, you're welcome.
Yeah, thank you.
You're welcome. Okay, anything else? So this will be on the second exam. When is that exam?
Next day.
Oh, really? That's soon.
Yeah, we did the same thing. Yeah.